Hi and welcome everyone. I'm here today with Mark Hancock of Macquarie University in Sydney. Mark, could you do a bit of presentation from yourself? I think that would be better than me doing it.
Hi, Brian. Sure. I'm a physiotherapist by background, I guess. Trained in Sydney. I've worked then for a while before I got into research. I worked in private practice in Australia. I actually worked for 3 years in America. Came back and yeah, just gradually, I suppose, moved into the academic world. Did a PhD in finishing about 2007, mostly focusing on back pain. And yeah, since then I've continued to research primarily in back pain, a range of different things from clinical trials through to more diagnostic studies like we're maybe going to talk about today. And yeah, that's pretty much it.
That's pretty much it. I think let's dig into that because the subject today was about diagnosis and pathoanatomy. And there's a few of your papers, and a recent one came out in 2022 that I find quite refreshing in the world of non-specific low back pain, because you've kind of you seem to have like an interest in both highlighting some of the pathoanatomic pitfalls, but also like highlighting that we might have to look a bit further into the pathoanatomy. So you kind of, if a patient comes into me, there seems like a general acceptance that we're triaging that person, and the majority of that patient goes into a box that's called non-specific low back pain. Is that a fair way of saying it?
Yeah, absolutely. And I suppose I like your setup that I'm interested in both sides of this. So I think um, yeah, there's people who sit very strongly on one side of this fence or the other, that all diagnosis is bad or that, we absolutely need diagnoses and we should be doing it. And I guess my research has led me to think that at the moment we're somewhere in the middle. And so I find it a pretty fascinating topic.
Yeah, yeah. And like the way I understand the term non-specific low back pain is that it's, especially within the last like 3 decades, it's been very accepted. But it's actually, if we go a bit further back, it's developed from the surgeons world. From like the non-specific group was a group that they didn't have anything to offer, so they gave them the non-specific low back pain term, and then it's kind of integrated within the rest of the rehabilitation world. And to some people would argue that it leads us away from being more specific and more curious within the tissue. And some people would argue that no, it's quite a fair way of saying it, because at the current space and time, we can't really like get into a specific pathoanatomic diagnosis anyway.
Hmm. Yeah, no, look, you cover a fair bit there. I suppose I think the history is interesting and maybe let's start there. So I think most people actually misunderstand the history. And when you go back and look at it, the people who really originally recommended the term, I think were largely just trying to be honest and say, actually, the evidence says we're not good at identifying the cause of pain. And there probably was a period where nearly every physio and chiro and doctor would say to a patient, you've got disc pain or facet pain, that, they felt they had to give a diagnosis. But the reality was they were completely inaccurate, or really there was no evidence that we could do that with any precision. So I guess there was acknowledgement of that, and at the same time an acknowledgement that back pain was clearly complex and that understanding the tissue pathology wasn't necessarily critical to managing those patients. So I think historically that's where it started. But the other thing, in those really key original papers, they also said, this is where we're at now, but this is not where we want to be in 30 years. In 30 years, we do want to understand the cause better. We want to be able to break down this non-specific term. And I guess that's one of the things that we were raising in that paper, and we've raised a couple of times, is this term was never meant to, in our mind, be forever. It was meant to be a kind of placeholder until the research caught up. And I think that's one of the problems in the field.
Yeah. Um, and when you looked into that recent paper from 2022, What did you find in that one when you looked into it, into the data on that?
Sure. So when you talk about the paper in 2022, again, I think you're talking about that kind of discussion paper
Yeah,
around some of the issues. Is
yeah,
that fair? So
that's
in itself,
the reconsidering non-specific low back pain, like
sure.
where are we now and where are we
Where,
going to?
yeah. So obviously it itself is not a study. It's really us, it's a discussion paper, I
Yeah,
suppose. But of course we went and looked at the literature as part of writing that. And so I suppose some of the key things that we're trying to emphasize and that I think are kind of important in the literature are, at the moment, there actually is evidence that some of these imaging findings, let's call them as a marker of pathology, that they are related to back pain. So I think there's this belief in the field that there's no relationship at all. And I think the evidence is pretty clear that there is a relationship. But on the other hand, the evidence is also clear that the relationship is quite weak. So then what do we do with that? And I think the problem and part of my frustration is then people interpret that complex situation in the way that suits them. So for the people who don't believe in pathology, they say it's weak, there's nothing going on, or they just really say there's nothing going on, and they say it's just not relevant to back pain. And then other people will say, well, yeah, there's stuff going on, and they hold on to we can diagnose, the source of back pain, despite the fact that we're not very good at doing it. And at the moment, those things are not very prognostic. They don't tell us a lot about the future. And probably most importantly, at the moment, we don't have evidence that they improve care. And ultimately, that's the key thing, right? So, diagnoses in any part of medicine matter if they lead to better outcomes for patients. But again, and this is almost my main point, is that people believe that we've proved that's not the case. So, for example, that same paper, we sent it to a different journal beforehand and it got rejected. And interestingly, it was a physio journal. And the reviewers were just, in my opinion, completely biased to the fact that they didn't want pathology ever to become a big part of back pain. It was like they just were not open to that in any way. And they wrote statements like, we've already got really strong evidence. We've already proven that it doesn't improve care. Well, we've done systematic reviews to look at that, and there are literally no studies that have looked at, if you take people with different pathology, at least based on imaging, does that lead to better outcomes with different types of, let's say, physiotherapy treatment? So it just simply doesn't exist. So it's that huge misunderstanding in this field that we've proven that imaging is not important or pathology is not important, and we haven't. But we haven't proved that it's important either. So I guess what we're really trying to say in that paper is we're not making the progress that we've wanted to make in back pain. I think most people would acknowledge that.
yeah,
So let's not dismiss understanding of back pain. When you talk to people in other areas of medicine and you say, well, I'm a back pain researcher, we don't understand the causes of back pain and we don't understand how our treatments work, really. They're like, well, how are you ever going to come up with good treatment? How are you going to improve things? And so I think there's a lot of basic science, whatever you want to call it, research to better understand causes, I think is still makes a lot of sense to do.
yeah, yeah. Yeah, because it's like it's kind of been the general acceptance. I'm biased of that too, to some degree, that well, it hasn't shown any difference when we were like in the bio world, but so therefore we don't have to do anymore. But then again, when you look at the data, not really that much has been going on there, right? So
Yeah,
because of the way we've spoken about this for the last 3 decades, it's kind of become less of a topic. So that's why I found your paper last year very refreshing. But you also made the statement back in 2011 where you also did a discussion paper with some of the same people and other people like Mark Laslett and Bart Coase as well.
yeah.
So I think yeah.
Yeah, so I'm not sure too much has changed, to be honest. Yeah, 2011, it was early post PhD, and I was like, oh, this is driving me crazy. Let's at least um, bring this to the table.
Yeah.
But to be honest, research is driven by funding a lot. And it's such a controversial area that it's really hard to get funding to investigate those kind of things. So I talked to you about writing a paper, and you've got an edit, a reviewer that doesn't like it, can send it somewhere else. But the competitive nature of funding often means that it's the more conservative things, unfortunately, that kind of get up. So I do think ultimately we will need to fund big projects that truly are designed to do this. So if you look at most of the imaging studies that have been done, including some of the ones that I've done, they're often attached to another project. We published a study not too long ago that's one of the bigger imaging studies using data from Germany. And, we had 1,000 people who'd been imaged in a cohort study, and that's unusual in the imaging studies. But that wasn't what that study was designed for. It was designed for things. And so we've been able to try to look at the imaging. But you know what? If that was the primary question, you would have done it very differently. You would have collected better images. You would have reported on those in a different way. So most of the studies in the imaging world and back pain are really poor quality because they're not the primary study. They're not funded properly.
Yeah, and then you're touching on a totally different thing, but very interesting thing as well, Mark. Because I just spoke to Kieran O'Sullivan a few weeks ago, and he said more or less the same as you're saying right now, that the funding is kind of to some extent dictates where you're going.
It's true,
Eh,
yeah, and that's I suppose a lot of research, who knows who's right, but a lot of researchers will say the wrong things get funded, or they'll even honestly tell you, maybe over a quiet beer that, they don't put in the project they think is the most important. They'll put in the project they think they can get funded. Yeah.
Yeah. How do you like, or what's your perspective on the argument that now we've looked at back pain for the last 3 decades through the lens of the non-specific low back pain, and it hasn't really changed. It actually just gotten worse. People are attending more healthcare, more people are getting back pain. Like, do you think that's a valid statement to use to say, okay, we need to go some steps back where we need to look more into the pathoanatomic way, or is it just those people being biased towards the pathoanatomic that's using that as an argument? And is it a fair argument? I guess that's what I'm asking on your perspective for.
Yeah, it's a great question. Again, sorry to sit on the fence, but I think there's both sides to this. So I think the fact that we've made limited progress is clearly a justification that we need to better understand the condition. I don't think there's a lot of doubt about that. That said, I think we're also overly negative about the progress that we've made, and there are some more positive findings coming out, and we've got some coming out before too long. And I think some of these biopsychosocial approaches to back pain that really are starting to consider all the elements of a real patient, and focus on those and come up with really clear problems that they think are individualized to that patient. I think we're starting to make some progress. And so I suppose just to kind of park that for the moment, the thing with imaging and pathology generally is, whilst I think we need to do research to better understand it, I understand why some people are really worried about that, because we've seen it in clinical practice, and I've seen it in our trials and stuff. There is no doubt that used poorly, imaging, if we just use imaging again as an example of a focus on pathoanatomy, and I'm almost using those words interchangeably sometimes, it absolutely can be harmful for patients. I'm absolutely convinced of that. But this is a critical point again. It's not the imaging that's harmful, it's how it's explained to patients. So I've seen patients be incredibly reassured by imaging and say to me, look, Mark, I remember a patient a few years ago whose parent had cancer and had died of bone cancer. and she had back pain that was classic non-specific back pain. According to every guideline, she in no way was an appropriate patient to go and get imaging. But she was, because she was completely freaked out that she had cancer, and it didn't matter what we could say to her, that wasn't going to change until she got imaging. But we imaged her and we explained to her that her imaging would find degeneration, all sorts of things. She got imaging and she was 80% better a couple of days later. And she laughed at herself, but she said, Mark, I just needed that reassurance.
Yeah.
So again, we oversimplify everything. All imaging is good, all imaging is bad. Imaging used appropriately can be incredibly reassuring and good for patients. But of course, we hear horror stories and we see them, and they're true, where patients have got imaging, they're completely freaked out about it. And, and I think, and Kieran would have talked to you about, interventions that work really well with some of those patients. And for some of those patients, the most important thing would have been for them not to get imaged. So again, it's this murky world of, a bit more nuance. When is imaging appropriate? How are we using it to kind of move forward with patients?
Yeah, no, I think that's it's truly correct what you're saying, and we're seeing that in the clinic on an everyday basis as well. And that's why I also think the nuances are important, as you say. But I also think it's important that there's a difference in using imaging in a trial, and to get a layer deeper, and then how we use it in everyday life, because it should be like the trial that kind of informs us clinicians of how it should be used in their everyday life. And I mean, so not doing one thing doesn't necessarily mean you couldn't do the other thing with a different purpose, right?
Oh, look, I completely agree. And again, sorry to kind of complain about my granting experiences in the past, but
Yeah,
this is from many years ago, I remember a grant that many of us put in, and it basically got sunk because one of the reviewers said we shouldn't be currently imaging people, who have back pain. And we're like, we're not recommending it in clinical practice. We're saying let's do a clinical trial. Let's do a trial of it. We agree with you 100% that right now it should not be used in
yeah,
day-to-day practice. But that doesn't mean that we shouldn't go and do some research. And that's just such a simple concept to me when you think about most areas of medicine. You can separate out investigation, you do all sorts of tests in terms of research, but you're not suggesting them in clinical practice at that stage. So yeah, it's a shame that it's just such a divisive area that people feel very, very strongly. But I do understand the group of people who are trying to limit inappropriate imaging at the moment, and we've done huge amount of research in that area. So I've done a lot of my research in the last 5 or 10 years as being about trying to reduce inappropriate imaging. So I absolutely agree with that.
yeah, and we've done some of the same up here, just in a smaller scale. And talking with GPs about it, they actually they like it. They like the conversation, and they like the education that lies within it on how to help people instead of helping them with an X-ray or an MRI and stuff like that. I think,
Yeah.
yeah. So we already talked about nuances a lot, and I like when people say it, because because you're obviously not too biased towards some. And there was a paper in 14, and I think there was a follow-up in 15 by Brinjikji. I'm not saying it right, in regards to imaging.
Yeah.
Um, I've had a hard time, like, quite understanding the way that paper was used, because it seems like it's in the general way it's been used like, or what, at least what you hear in public, is that you could find all these sorts of things on the imaging and stuff like that. And I use it as well for my clients, and when we had a chat about this, about normalizing age-related findings and stuff like that. But it's been, to some extent, it's also been flipped, that it doesn't matter, and you already touched a little about that. But there's also like the fact that if you look at some things, just like an extrusion, you will almost never see the extrusion on asymptomatic people, as far as I understand the paper. So there are
Yeah.
some data out there, despite it comes from a very limited amount of data when they polled it.
No, look, I think I'm so glad you raised that paper, and I'm going to say those papers because there's two. because I think they really cover a lot of what we're talking about. So for those that are less familiar with these papers, the first one, and the one that nearly everybody talks about, looked at case control studies and looked at people with and without back pain, and looked at, ignore all that. That's the second one. But the first paper really looked at how common these imaging findings are in people at different ages. And as you said, it reports that they're very common in people who don't have back pain. And that's the message everybody's heard. And that's true. And exactly like you, I use that to reassure patients. But people don't like the nuanced, complicated message. And the truthful message is they published another paper, which in some ways I think is actually more important, where they compared. So it's not just how many 7-year-olds have these findings, but it's if we compare people with pain and people without, are they more common in people with pain? And the short answer is they are. So in that paper, they report odds ratios of 3 to 4, which are reasonable odds ratios for many of these findings. So basically the conclusion when you put the two papers together for me is quite simple. These findings definitely occur in people without pain, but they definitely occur more commonly in people with pain. And most people ignore the second one. And just as an academic kind of way of looking at that, the first paper has been cited about 3 to 4 times more than the second paper. So people prefer the story of these are common in people without pain. They don't quite like the story as much, hang on, but they're more common in people with pain. So, and I've done one of the studies that was included in that. And yes, because we were looking at, are they more common in people with or without pain? And for basically every imaging finding we looked at, they were more common in people with back pain or a history of back pain. So when I talk about this to people, I say, well, what about things like high blood pressure or atherosclerosis, these kind of things? Do they occur? Does high blood pressure occur in somebody who currently has had no cardiovascular event? Absolutely. But just because it's common, maybe high blood pressure, I don't know the statistics, but maybe 50% of people in the community have high blood pressure who've never had any major cardiovascular problem. We don't go, oh, well, therefore it's irrelevant, can't be related to anything. No, we know that it's more common in people who've had cardiovascular events. Well, that's just like back pain. But what we know more about in that case is we know that it predicts your risk of something into the future, but also it's a target for treatment. And if we treat it in that world, we know that we can get better outcomes. That's what we haven't done in back pain. So we actually do know that these things are more common in people with back pain, just like blood pressure. What we haven't done are good enough studies to see, do these things predict increased risk in the future? And we definitely haven't gone to the next stage of saying, okay, if we take people with those particular features and we target them with a logical therapy, and that's challenging, what's logical in our world. Yeah. And if we give them a logical therapy, will they do better? Okay. And when we laugh at logical, just to go off on a tangent, the antibiotic trials are incredibly controversial, of course, and I'm sure you know about them and most of our listeners will know about them. But whatever you think about it, they've taken some logic to it, right? They've identified this is a finding that we believe is based on an infection. Do we have a treatment for that? Yes, it's antibiotics. Do we treat them with antibiotics? What do we find? And the first study found big reductions in pain, much bigger than most studies.
Are you talking about the modic changes now?
I am.
Yeah,
So
the Albert study.
Yeah. And then there's been a follow-up study to that where, again, people with different agendas have interpreted in different ways. I don't think there's almost anything more controversial in our field than this kind of area. And we're doing a Cochrane review on this at the moment, and it's incredibly controversial.
Yeah.
But ultimately, the second study still found effects from the antibiotics. Now, we haven't solved it all. Is it just because antibiotics kind of work across everybody? Is it specifically the modic ones, etc.? But you've at least got to say, instead of being, I suppose, really resistant to that work, here's a group of people who maybe are trying to identify a specific cause, treat it with something targeted at that, and hopefully find better outcomes. And I think there's an argument we need more of that.
Yeah, there's actually just I just got mailed from a friend the other day a text. It's a new study from Christensen or Christopherson that also looked at antibiotics compared to placebo
Yeah,
in regards to Modic, and they didn't see any change in edema. So that's just another one that kind of is a bit like that, right?
yeah. Exactly. And we've got to keep looking at these things, and it's good not to have one study on something new and go, well, that's it. We know the
Yeah,
answer. Of course, we need to, and the more you do trials, what you realize is that there's no one trial that answers all the questions. Every trial leaves it a bit uncertain about did it work because of this reason or that reason. And, so I guess we just have to be a little bit patient. We need more money so we can do more of these good studies. Um, but I think some of those good trials, and I guess you're kind of touching on it, are looking at the kind of key clinical outcomes that we really care about pain and disability. But they're actually trying to measure markers as well. Like what's changing? Is it working the way we think it's working? Does the modic change in size or intensity, for example, at the same time as patients' pain and disability change? So,
yeah,
for example, on a big tangent, one of the sciatica trials looked at, so this is the one by Wilco Puhl in New England Journal of Medicine quite a few years ago now, but really great trial, compared early surgery versus wait and see in people with, clear sciatica and disc herniation on MRI. And the early surgery was clearly better in the short term, but
short
not in
term.
the long term. But they did a follow-up study where they looked at, did the changes in the MRI correlate with the changes in the clinical symptoms? Um, and they found almost no relationship between that. And that's a really great study. And there's very few studies like that that have actually looked at longitudinal things. So we need studies like that really see, well, does this change? Does this feature? Does this does this modic change? Does the inflammatory marker, does something change at the same time as people's pain change?
Yeah,
But there are literally a handful of studies. And again, if we use that one as an example, it wasn't designed to do that. The primary question was the RCT. And so the way they did that wasn't great. But in my opinion, we need a lot more of those studies.
yeah. It seems like it's easier still to get a study going on looking at an intervention in a heterogenic group, right? It seems somehow to be easier funded because people keep pushing them out there.
Yeah, absolutely. No,
Um,
I think that's true. But I think there's a push towards, if you're going to do that, try to collect some information along the way to help you better understand some of that heterogeneity, etc. Yeah.
yeah, Mark, there's also another thing in regards to pathoanatomy, and that's the thing that you touched on it just in the beginning of our chat, and I think I would like to come back to that perspective now. That in 2007 you did a systematic review looking at our ability to diagnose into a specific pathoanatomic structure, and we didn't really have the data to tell us that we had the ability to, in the clinical setting, unless we had diagnostic blocks, to diagnose any specific thing. And what it seemed like what we were best at was identifying discogenic pain by clinical phenomena of centralization.
Yeah,
But yet people are still like, this is, you touched on it, we've divided to some point that some people have gone like, okay, I know it's not possible, I know it's not reliable, and there's no validity in trying to diagnose a facetogenic pain, and yet the other part are still like, okay, you definitely have facet pain. I
yeah,
mean, can you just, what are we currently able, based on the data we have now, to diagnose a facet joint? Are we
sure.
to
No,
that in
great
clinical
question.
practice?
Yeah. So we've just updated that review. It's now a Cochrane review, and I don't think it's published yet, but the protocol's published and it'll come out very, very soon. There's more studies, but there's surprisingly few extra studies when you think I published that in 2007 as my
Yeah.
PhD. And it's an example of the lack of research in a field like that. So just to go back a quarter of a step to help people understand this area is fraught with one key problem, which is what's the reference standard that you compare to? So ultimately, if we're going to say, does imaging identify disc pain? Does a physio test identify disc pain or facet pain or sacroiliac pain? You need something. You need a gold standard, a reference standard to kind of identify that. Everyone agrees there is no gold standard. There is no test that everybody agrees on. What there's a lot of controversy about is, are the best tests, which is really what a reference standard means, are they good enough to believe? And so before you can think about the other tests, you need to make that decision. And we felt that they were, and I still believe that they're the best we've got. They're good enough to kind of have a bit of a look at this. And so just to be clear, for example, with the disc studies, they are usually studies that compare to discography. So discography is where you stick a needle into the disc, you put fluid in there, you pressurize the disc, and you basically see, does it produce the patient's pain? Now, not surprisingly, you think, I'm going to get a lot of false positives with it. But done well, as best as I understand it, and I'm far from an expert in this, done well, you always have control discs. So you only consider a disc positive if the disc above and, for example, the disc below don't produce pain. So now you start to reduce your false positives because it's only positive if the other one doesn't hurt, for example. And it's all blinded to the imaging, obviously, when it's done well. So what we found in that study, and to be honest, what we found in the update is not radically different, is that there are some findings, some imaging findings, and as you mentioned, one or two clinical findings, not many, that increase the probability that the disc or the sacroiliac joint was the source of pain. And I avoid facet because we still, based on the current review, don't really have good tests that help us with the facet. But if we just stick with the disc for a second, the critical thing again is that these tests are not rubbish. They don't tell you nothing. They're not just noise, but they are definitely not perfect by any stretch of the imagination either. And they're right in the middle. They're in that gray zone. So, for example, they might, if you think, well, roughly, let's just hypothetically say 40% of people have discogenic pain. If these tests are positive, for example, if you have fairly significant disc degeneration, or if you have modic change or something like that, they might increase the likelihood that your pain is coming from the disc to about 60 or 70%. And what I really mean is they increase the likelihood that discography would be positive for you to about 60 or 70%. But if you don't have any degeneration, it reduces it down to 20 or 30%. So what does a clinician do with that? So I'm a big believer that just saying, well, that's complete rubbish isn't true, but it's how much weight you put on that piece of information. And so the critical thing for a clinician is, well, does that tell me what to do with a patient? Does it change my management if I think that the person is 70% likelihood to have the disc as source of the pain or 20%? At the moment, it probably doesn't change your management a lot, I don't think. It doesn't help me as a clinician manage that patient a lot. But do I completely ignore it? No. To me, it's one of the 30 things that I'm thinking about when I'm thinking about how to manage a patient. And I think that's a more sensible way to think about it, that it's one other piece of information. So it's not evil, it's not wrong. Most of our other assumptions, we make assumptions that somebody's beliefs about back pain are critical to their outcome. Well, we don't have a test to prove that. But we incorporate that into our management. We think that the way somebody is moving is contributing to their pain, and we incorporate that into our management. So I think personally that it's not something we should spend lots of energy on trying to kind of make this decision. But would I say to you, when I see some patients at the end, I have a gut feeling that it's more likely disc pain, sacroiliac pain should be more obvious, maybe even facet. Yeah, I think I do, but I don't think it changes my management much.
No, but I think it like yeah, you're putting in some very elegant and very important messages in the way you answer that question, Mark. Thanks for that. But I also think, and I can't really get rid of that thought that keep telling people that they had facetogenic pain, as an example, sometimes can have detrimental effect, because we're telling ourselves as clinicians that we have the ability to do something with a very high level of certainty, which the data tells us we doesn't. And it, just as well as it can be reassuring to the patient that a clinician is certain and shows that they're secure and they've got it under control. It also, like, if we as clinician tells ourselves with too much certainty that this patient is having this problem, I think we are more likely to get carried down a slope that's not controllable and that's not fair within practicing evidence-based medicine.
I agree 100%. And so it's a very long time since, well, it's rare, very rare these days that I would, at the end of assessing somebody, mention a pathology to that person. I used to a long time ago, but and even then I would argue I tried not to give it much weight. So I
Yeah,
agree 100%. If I see somebody and they said, "Oh, I saw my physio last week," and they said I've got L5 facet joint pain, whatever, straight away that's red flags to me. Like, it is that, and it's the unintended consequences, like you said,
yeah,
that patients hear bad messages and it sounds bad to them, and it can lead to them, both them but also clinicians thinking very structurally and therefore only thinking structural treatments, and we don't have good structural treatments. I mean, that's the simple reality.
yeah,
But I would give you an example of how I might do it. So if I think that somebody's got a very mild and annular kind of tear, let's call it, okay, and I'm thinking, well, see, to me, that's not threatening. I think those recover well. That's what most people with back pain have.
yeah,
So what do I think? So I equate that to like having an ankle sprain. Okay. So we don't get freaked out about somebody telling us that we've got an ATFL injury. Why is that not threatening? But knowing that we've got a outer disc annulus ligamenty kind of structure threatening. So it's very interesting why we attach threat to one. So if you've got an ATFL sprain, I would argue that directs sensible care. So in my mind, that's an acute thing which heals well. If I gently load that in the early period of time, that'll be good for it. And then before long, I should fully load it. So I take exactly that same principle to an acute, what I think of is a mild annular sprain of the disc. I go, okay, it's going to heal well. Maybe by me moving it a bit earlier, it'll heal better by me making sure they do move. So I might, in my mind, even think about directions of movement that consciously load that. So the McKenzie approach is really interesting because the McKenzie approach can be given, some people love it, some people hate it, blah, blah, blah. And
definitely
obviously,
divides people.
yeah. And it just annoys me that everybody's too divided by things. And so let's think about that. So we don't know. And they used to talk about a DISC model and then they stopped talking about a DISC model, to be current and stuff. So some people respond to extension, okay, for all sorts of reasons. But if you think about it, with your ATFL sprain, for the first couple of days, what do? You probably don't invert your ankle very much, do you? Most people would say it's pretty sensible for 2 or 3 days not to invert, where you stretch that tissue, but most people would say it's great to keep it moving. So if you think about a posterior annulus mild injury, well, if I flex, that's the same as inverting my ankle. Maybe for a couple of days, that's not a great thing to do. If I extend, that's the same as everting my ankle, which is movement and is probably really good for me. Okay. So I'm creating movement that's not causing more damage or trauma to that area. It's letting it settle down. It's, letting the inflammation settle. And so to me, that makes sense. And maybe that's why some people do really nicely with 2 or 3 days of that. And then if you do the McKenzie model really well, what do? As soon as that person can flex, you flex them. Like you don't, that's again, people misunderstanding things. Like I've done the McKenzie ADD. Don't consider myself a McKenzie therapist, but when I do that model, I would be, if it's not the first day, it's the second day that I'm trying to get people to go into their more difficult direction, which may be flexion. Well, that's exactly what I do with an ankle sprain. I'm now starting to get them to invert. So to me, that's kind of bringing a logical pathology approach to it, which actually leads you down a really positive treatment pathway, which is move. It actually reassures me that this injury should do well, because I'm just thinking of it as a soft tissue kind of injury, rather than freaking me out that this won't do well. And interestingly, and I'm sorry, I'm off on a tangent here, but as you can see, I'm kind of
Just keep
passionate about
rolling.
some of this stuff, is that some of what we're finding is actually on imaging. Sometimes it's the people who have no imaging findings who do worse, because there is no pathology. They are probably the people who have a lot of psych stuff going on and whatever. And, simple kind of pathology things. And again, I'm oversimplifying that because we haven't done the research, but we're starting to get some hints of this, that things like herniations, particularly sequestrations and, these types of things, well, they do really well. And anatomically, we know that they do well. If you look at imaging in those patients, they nearly all, I think when we did a review on it, 95% improve or disappear within 6 to 12 months. So why do we always think that's threatening? Wouldn't you kind of like to, now we've got a biological rationale to tell somebody why they should get better. You've got this thing which is causing your pain. We know that thing goes away. Therefore, your pain should go away. Do you see what I mean? I think it's all in the delivery of this information. And, I think physiotherapists and stuff are in the absolute perfect people to convert this information into a positive message, but they have to engage with it. They have to understand it rather than just go, all imaging's bad, all pathology is not relevant, that kind of thing.
Yeah, so now we just kind of touched on two sides, because I think there's the other side that keeps telling people that they have some kind of pathology, but they can't detect it. And then we have the other side that says it's irrelevant. So we actually come to the point, which I really hope this talk takes us into, Mark, because I think it's very interesting to look at both sides of it. And I think you've done that in a very nuanced and a very honest way. And I like that. The thing that I have a final question, Mark. You tend to you did it in 7, you've done it in 11, you've done it in 22. Are you kind of, if you should be biased or be honest, are you kind of biased in regards to the pathoanatomy, or you just feel obligated as a researcher to look into this field of what we're knowing and letting people know that you don't think we're there yet? You get my question?
I absolutely do. That's a great question. Why am I still interested? Why do I keep banging my head against the wall on this?
You said that.
Yeah,
I
I
didn't
know.
say that.
Yeah. That's a really great question. I think it's a bit of both. I genuinely believe that pathology is part of back pain. And I genuinely believe that if we had enough money and enough good research, we could improve outcomes by doing this. So I would love to be part of that. I'm starting to give up's too strong a word, but it's a huge job to be done well. And there is not one study that's going to do it. And I'm becoming less confident it's going to happen in my lifetime. But I hope that smarter people than me do it. I hope that what you need are seriously not, small amounts of money. You need a group to give $50, $100 million to this and get a group of people who come from every background. We got a bunch of physios. I don't know anything about imaging, and I'm trying to do imaging studies. You need teams that have the real experts in pathology and imaging and physio and different stuff to really truly tackle this problem. So I'm fascinated by it. I think it's important for the field, and I guess that is one reason that I do it. I'm not sure if it's actually answering your question, but I'm also, and again, I've got some trials that I can't really talk a lot about the results beyond kind of saying they're making me pretty excited. And I am a strong believer that we can actually manage people so much better than we think we can at the moment. And then we do have good solutions for some of these people that don't require a deep understanding of an individual person's pathology. And so I'm really passionate about that area of research as well. But I just want the two worlds to talk to each other and come together and not almost fight against each other, I suppose.
Yeah. Thanks. Just stay in there, and it's okay if you come up with a new one in 3033 or something like that.
All good. We'll see.
So you got a lot of trials and research coming up in the following years, Mark. That's what I'm hearing. If people have kind of felt that our talk has been inspiring enough to dig a bit further into some of your research, where do you advise people, like, are there certain papers, despite the papers that we've been going through today, are there certain papers that you think these are really landmark papers that you've been involved in that people could look into it? And don't
Yeah,
be shy,
geez.
just let us
Yeah.
know what you think.
Oh, look, I think that's a bit difficult to answer because it depends on which element of this you're interested in,
Yeah.
etc. I mean, I do think in terms of understanding the pathology kind of question and the imaging question, I think there's a couple of important papers, some of which we've talked about today. I think understanding the prognostic value of those imaging findings is important. And, Daniel Steffens published a review, which I'm part of, in European Journal of Spine 2013. But again, we will probably be publishing that update within a few weeks, hopefully, or a month or two. I think understanding that is important. So I'd encourage people to read that. I would encourage people to read the Brinjikji papers that you mentioned, which are in American Journal of Neuroradiology around 2015. But read both. Don't just read the one that everybody reads. I do think the update of the diagnostic review, which will become a Cochrane review, I think it's important for people to kind of read some of those papers. I think they start to cover some of the kind of key issues around what we really do and don't know around imaging at the moment. And, I can point you to individual papers that find bigger associations or smaller associations. But I guess if you go to those review papers, hopefully you're seeing the balance. But what you'll mostly see is we don't have a lot.
Yeah.
You'll see that we really don't have enough studies, but there definitely are some studies that suggest there's something going on. Probably, I don't want to kind of go off tangent too much and also talk too long, but one thing that I will just mention, if it's okay, which we haven't really touched on, but I just think is such a massive flaw in the field, is that we measure these imaging findings in the crudest way possible. So to give you a tiny example, disc degeneration, yes or no? Like, what does that mean? And hang on, you've got 5 discs in your back. So do we count how many you've got, or do we just say yes or no? And do we care if you're 20 or you're 80? I mean, again, I come at this as a physio, not a radiologist, and I go, this just makes no sense. Nobody would do this. So one bit of work we're doing that I'm really quite excited about, but it's at very early stages, is actually trying to look at disc degeneration, for example, in a standardized or normalized way. And so the example we give to people that's maybe easy to grasp is when you go and have a bone density test for, you've had some fractures and stuff.
Yeah.
They don't just give you a score, they give you a Z score, and it adjusts for your age and your gender. And it says, where do you sit on what's normal? So I've had a student recently trying to do something very similar for disc degeneration. It feels so bizarre that we haven't done this. So actually creating like a Z score. And what he's found is that a person who might, let's say on a Berman scale, or even if you're taking a quantitative measure, that's probably a better way to think about it. If you think about a quantitative measure of disc height, so if you just measure that and you go, it's 8 millimeters, and you say, where does, and then we see whether that predicts something. But if you now say that's 8 millimeters in a 5-foot person or a 6'5" person, and they're 20 or they're 80, it leads to completely different conclusions. And so isn't it kind of problematic that we haven't kind of done that yet? Like that just seems like, wow, how have we not done that? So sorry, off on a big tangent.
No,
But
no.
in terms of papers, if anybody wants to talk about any of this stuff, just please contact me. Like I said to you earlier, I don't do a lot of social media, but I'm super accessible on email. I do use ResearchGate in terms of all of my papers are there, and as many as possible, are accessible. And if people can't access any of the papers, just contact me and I'll find a way to get them to you.
Well, thanks a lot, Mark. It's been really a great chat, and your experience, your continued participation within the field. Thank you for that, and thank you for sharing your insights and taking your time for chatting with me this early morning for me and this late afternoon for you. You probably need to get home to your family, and I need to get started some work.
Sounds good. Thanks for your time.
Thank you.